Okay, welcome everyone. Thank you so much for joining us tonight. As a first reminder, please make sure that you are on mute. Not everybody is automatically muted when they enter the room. So please make sure you are on mute. Feel free to drop your name and any additional info in the chat box. And also we will be using that for any questions that you may have during the webinar. So welcome to this special event sponsored by Doctors for America's Gun Violence Prevention Anti-Racism work. We really appreciate all of you joining us to connect on this impact of racism on marginalized communities within medicine. My name is Farheen Qureshi. I am a physician and a trauma surgeon in Baltimore, Maryland. I am also on the National Board of Directors of Doctors for America and am part of the Gun Violence Committee and its anti-racism work. So I appreciate all of you all being with us here today. We're going to be talking about multiple things, thinking about questions like, should doctors be required to train in combating medical racism in order to maintain licensure? And how should physicians and medical students connect with communities in trauma? At DFA, we believe it is past time to demand racial equity from medical institutions and intentionally teach anti-racism practices at all levels of training within healthcare. DFA acknowledges that it needs to do more and medicine needs to do more than it has done in the past in terms of connecting with communities in trauma and providing our members and all people in medicine with better support who are experiencing racism firsthand as physicians or other healthcare providers as well. It's important that we raise awareness, increase visibility, and that we are solution driven. So thank you again for being with us tonight. I am pleased to introduce our moderator for this evening, Ms. Kayla Hicks. She is a recent member of our Gun Violence Prevention Steering Committee, and she is the CEO of Sustain Equity Group. She has worked for 35 years towards eradicating policies, procedures, and social norms that create barriers for Black and Brown communities. She is committed to leading community-based violence prevention initiatives to ensure the voice of those most impacted are central in policy and program decisions. Go ahead, Kayla.
Thank you, Farheen, for the introduction and for your commitment to this work in reducing death or injury by firearm violence through policy advocacy and community partnering. Again, welcome. As a member of Doctors for America's Gun Violence Prevention Steering Committee, I am humbled and honored to stand beside you all. We've come so far and we still have a long journey ahead together. Retired NBA icon Michael Jordan once said that talent wins games, but teamwork and intelligence win championships. It's my hope that tonight's conversation will be the beginning of a championship team preparing for the big win to dismantle racism. In the healthcare system, leading by example. Our goal this evening is to begin the dialogue in a safe and trauma-informed environment to identify and dismantle medical racism in marginalized communities. Also, we know this is not just an external issue with patients, but an internal issue with Black and Brown doctors who are experiencing racism in the healthcare system. And I am glad to see Doctors for America is just getting started and providing some tools and resources for their members, supporters to combat racism in the healthcare system and beyond. Later in the hour, after we hear from our distinguished panelists, we will take your questions. Please use the chat feature in the Zoom as you are listening to the speakers today. We will address your questions soon after hearing from our panelists. Let's get started. First joining us this evening will be Dr. Jeff Ritterman, who is a retired cardiologist and serves on the board of I just lost the I'm so sorry. He serves on the board of San Francisco Physicians for Social Responsibility, and his past work included delivering medical supplies to Salvadorian refugees in Honduras and Costa Rica during the Salvadorian Civil War, and to the African National Congress's clinic in Zambia before the end of apartheid. I am so excited to have Dr. Ritterman here to talk about anti-racism in healthcare. Heart disease is the leading cause of death for African American women. And considering the impacts of racism on the body and just life itself, what a way to start a discussion today. I'm really excited about it, and I'm hoping that we'll get a chance to not only talk with Dr. Ritterman today, but also continuously have him in the future work with us as we begin these new partnerships. And then also with us is Dr. Sadie Schaaf, and she's been working in the field of mental health for over 31 years. Dr. Schaaf is a licensed social worker providing psychotherapy to individuals, communities, and to groups. And she also specializes in LGBTQ and specializes in sexual trauma. Dr. Sadie Schaaf has been the example of Black girl magic to me. She survives and thrives in the medical industry against all odds, and she has stood the test of time in many unfortunate situations and has been very influential in my life in the way that I educate and teach communities around the nation. She is an educator, a speaker. She is both here in the United States and in Europe. She is the CEO of DSQ Communications Healthcare Group, where she offers and supports marginalized communities in Virginia. And then we have Assistant Police Chief Orrin Gallup, who joins us from Hampton, Virginia Police Division, where he has been since 1993. He is the commander of investigations in charge of crimes against persons and property, special investigations, financial crimes, and violent crimes and gangs. He is active in developing strategies to reduce violent crime, especially among youth. And historically, we know that law enforcement has been known for its roots in systemic racism. And as police departments across America face the scrutiny of racist policing practices, Black police chiefs and Black sworn law enforcement officers are caught somewhere between two worlds that don't align. Policing in America remains led by white males, and we're hoping that Assistant Police Chief Gallup's experience in this field and dealing with racism in law enforcement will help us to learn more about his successes and challenges, and hopes for a more equitable future for us all. This evening, Dr. Ritterman will begin by sharing a presentation on combating medical racism, followed by the reactions and a discussion with our esteemed panelists, followed by an opportunity to answer your questions.
Well, great. I'm really just very thrilled to be here. I want to first thank Dr. Allison Volkman for inviting me and for doing all the heavy lifting on this, and to be part of this esteemed panel. Doctors for America's mission is putting patients over politics and ensuring that everyone has the fundamental right to equitable, high quality, affordable health care. And we're really going to focus on the equitable part tonight. Also, it's part of his mission is that doctors should take a leadership role in improving healthcare and ending health disparities. So that's what we're here tonight to inspire us all to take that leadership role. There's really no debate about medical racism. The American Heart Association called structural racism a fundamental driver of health disparities. The editors of family medicine journals said that racism is associated with poorer mental and physical health outcomes. The American Academy of Pediatrics issued a similar statement. The Institute of Medicine, now the National Academy of Medicine, said that unequal treatment led to unequal health outcomes in cancer, cardiovascular disease, renal disease, higher death rates in hypertension, diabetes, septicemia, kidney disease, hypertensive renal disease, cardiovascular and infant mortality. And we've all witnessed that COVID-19 has shown a real disparity in terms of who gets the illness and who dies from it, from inferior access, greater exposure, and bias in treatment. So there's no dispute about this. So it's really up to us to uproot medical racism. Can we see the next slide? We have with us tonight the president of my organization, Physicians for Social Responsibility in San Francisco. I want to send out a big shout out to Dr. Bob Gould. And really, our two organizations have so much in common and can work in concert. We work for the abolition of nuclear weapons, combating climate change, and also combating medical racism. So there's quite a bit we have in common. The next slide. So who are we tonight? We're really a group, we're up to 40 people who want to uproot medical racism. We want to become the leaders in that effort. And what we want to get out of this lecture is to be inspired, to learn a little bit about the scholarship that's been done, and for all of us to be able to continue our own learning so that we can inspire our colleagues. I'm going to go through a little bit of what I'm going to review. We're going to talk a little bit about implicit bias. I see the next slide. And then we're going to go to explicit bias. So I would assume that most of us don't really have much of an explicit bias when it comes to racism. But implicit bias is something that is hard to avoid. It's sort of like the air we breathe, and it affects us all. So we'll talk a bit about that. Next slide. And these are all the kinds of explicit bias problems that we'll go and cover. The next slide. So when we're talking about implicit bias, you can turn the slide off. When we're talking about implicit bias, we're really talking about what it is that has really gotten into our psyche without pretty much our awareness. We talk about being blackballed, being blacklisted. We talk about blackmail. We talk about angel food cake, and we talk about devil's food cake. I would refer you all to both a hilarious and poignant internet interview with Muhammad Ali, where he asks the question, why is everything white? Tarzan is white, and Tarzan is in the middle of the jungle, and only he can talk to the animals. He points out the African tribes in the jungle have been there for centuries, but only Tarzan can talk to the animals. So there's a whole implicit bias that we all get subjected to. I say peanut butter, you say jelly. So I would recommend that everybody go to the internet and go to the Harvard Implicit Bias test. And there are multiple tests. There's ones on race, there's ones on gender, and take a look at where you fall on that, because it's really something that we want to confront in ourselves. It's not about anybody being bad or wrong, but it's about realizing the power of what we're being subjected to in our day-to-day lives. So that's really a powerful learning for all of us. Excuse me, for all of us. You can put the slides back on, and let's see the last slide you had up. Go back one. So can you go back one? So back one more. So when we talk about explicit bias, I know that most of you have seen the Dr. Susan Moore video. I couldn't find it anymore on the internet. I think it's been taken down, but you remember that Dr. Susan Moore was the doctor who was made a video of herself while in the hospital, suffering from explicit bias because her doctor was denying her pain medicine and was denying her COVID medication. And sadly, she died from COVID just a short time after making that video. And she stated that I feel like he made me feel like I was a drug addict. If I was white, I wouldn't have to go through that. And her son confirmed, because she was a sufferer of the medical condition sarcoidosis, that whenever they went to the hospital, they had to go through a lot of work to get her treated properly. So this is part of explicit bias. This is what we see. And this is particularly evident in the treatment of pain. Can we see the next slide? And the one after? So, for example, in the treatment of pain, Black children with long bone fractures and appendicitis receive significantly less pain medication in emergency room visits than white patients. So imagine being a parent of a child who gets inadequately treated for their pain. Sickle cell anemia patients wait longer in emergency rooms than other patients before treatment. And the authors of that study on that phenomena concluded that it was because they were African American and suffered from sickle cell disease, and their status as having sickle cell disease appeared to contribute to the longer wait times, and those data confirm the patient's anecdotal reports. I can tell you that one of my best friends is one of the world's experts on sickle cell disease, who is a high school friend and a college roommate, and he works at Oakland Children's Hospital, Dr. Elliot Vichinsky, and he confirms that that in fact is true. But let's look at some of the anecdotal reports. Let's look at the next slide. So every time it's a battle, one patient said about her ER experiences, staff members suspect her of faking her condition in order to score opiates and view her as a non-emergency because she only has pain. So sickle cell crisis is a particularly painful condition. And they are mistrusted when they come into the emergency room and don't receive their proper treatment. I always dress professionally, said a retired school administrator. Nice shoes, interesting earrings, every hair in place, and Vogue-worthy makeup. And again, imagine having to do that when you go into the ER. The next slide, please. Now, why does that happen? It happens because medical students and medical residents have the miscomprehension that Black patients have thicker skin and less sensitive nerve fibers than white patients. And these misbeliefs date back to slavery times. The next slide, please. And let's just jump ahead, because I see I'm running out of time, to what's happening in terms of the lack of trust in the African American population and why there's a reluctance to take the COVID vaccine. That dates at least back to the Tuskegee syphilis study, when 600 desperately poor sharecroppers who had syphilis were lied to by the US Public Health Service. This wasn't a corporation. This was our own government. And they were lied to for 40 years, and medical treatment was withheld. Next slide. And the idea was they wanted to wait till they would die so they could autopsy them. And medical treatment was withheld. They prevented them from getting treated by the military. They were exempt from the draft. They allowed their wives and children to get syphilis. They withheld penicillin. And it's that loss of trust that underlies what we're seeing today. And can we see the next slide? So how does racism become biology? It's the everyday discrimination, what's called microaggressions, that causes our sympathetic nervous system to be turned on. And patients are always being vigilant. And that causes us to age prematurely. You can see that in telomere length, and you can see that also in increase in CRP, an increase in inflammation. And in addition, there's no drop in blood pressure when patients sleep. That's the normal condition. But they're always on guard, people who suffer these microaggressions. So that's part of why there's the premature death. And let's see the next slide. And we know that there's something called concordance. Patients who are treated by, if you're a Black patient, if you're treated by a Black physician, you seek care more often and you do better. and same true of Hispanic patients. So this is why that medical school pipeline is so important. We need to have enough Black and Latinx physicians to take care of those patients in order to have good health outcomes. And let's see the next slide. And this is the life expectancy by race chart. And you see that Black patients and white patients have a great gap, and that gap hasn't changed from 1980 to the present. And you notice the drop in the present, that's from COVID. You also notice that Latinx patients do surprisingly well, and that's attributed to having very intact cultural systems where they have good family support. But you see that life expectancy by race, it's all getting better for all of us, but there's no convergence. The gap continues. And let's see the next slide. And you see that infant mortality rates by race also show that Black patients and Hawaiian patients and Native Indian patients and Hispanic patients all do worse than white patients in infant mortality, and that continues to be a problem. So what are we being called on? And here's one of the people I suggest you read, Ibram Kendi, who survived his own struggle with cancer. And he asks us to be anti-racist, to take on racism and to fight against racism. And he suggests that we fight against racism in the same way we fight against cancer. And I know I'm running out of time, but this is the quote from him, and I suggest you read his book, and you'll see more about that. And the next slide is from Isabel Wilkerson's book on caste, and she suggests that we do something similar, that we break the back of caste by reaching across the divide that divides us. She's written 2 amazing books. One was a Pulitzer Prize winner, The Warmth of Other Suns, and the second is Caste. And the next slide are the resources I suggest you go to. Medical Apartheid by Harriet Washington is really the Bible of medical racism and uprooting it. And I guess I'm out of time. So thank you all, and really appreciate a chance to share all this with everybody.
Dr. Ritterman, thank you so much for the presentation. And I know that we are so short on time, and there is so much more that I know that you can share and want to share. A lot of that resonates with me clearly as a woman of color, as an African-American female. I see myself in a lot of that. So I would like to ask you if you're okay with answering the question of what brought you to champion to work in this space of reducing or preventing racism in the medical field?
I'm sorry, could you repeat that?
So what I'm asking is what brought you to the space where you are championing to prevent and reduce the medical racism? Like, was there an experience, or just was what brought you to this space?
Well, to go 40 years in medicine and not really be acquainted with this was kind of shocking. And I kind of felt ashamed, to be honest. So I felt like this is something I have to learn more about and share with my colleagues. So I think we all can do more. And you know, how could it be to go 40 years and not really understand that this was going on, and my colleagues were suffering from this, and so much of what we did in our day-to-day clinic work was not really appreciating this. So then I did a little reading and some self-education, and it really opened my eyes. So I felt the responsibility to share it. I wrote a few papers, and I'm very eager to share what I learned.
Dr. Ritterman, thank you so much for having the courage to share what you just did and to step up and be a leader in championing this work. It's going to take all of us together, and it's definitely going to take more people such as yourself that will stand up and not be afraid to help dismantle racism. And so one thing that, I just was thinking about as you were talking was Dr. Sadie Schaaf, who is here with us, and how she champions in her space with mental health. And when you said some of your colleagues that are suffering from this, I was wondering if Dr. Sadie Schaaf could join us at this moment, and to maybe tell us a bit more about what she has been doing and how this medical racism shows up in the work that she does. Are you there, Dr. Schaaf? I thought I saw you. There you go.
Yes, this is Dr. Schaaf. This is Dr. Schaaf, and I am here. Can you hear me?
Yes, we can hear you.
Okay. My name is Dr. Sadie Schaaf, and I work in the arena of mental health. And in this arena of mental health, working with both males and females, especially dealing with issues that have come up in mental health. For example, the discussion with regard to being in pain and dealing with pain, and how often African American women who were giving birth, being seen as clients, or women who were suffering from other issues with mental health, or having other physical pains that were related to other issues that they had, were often, in my work, they have talked about the idea of being thought of as drug addicts, seeking drugs, as opposed to attempting to get help with pain. In mental health, there's also been the arena of those that may have co-occurring disorders, and instead of even looking at the idea of perhaps focusing on the mental health issue, maybe like of PTSD along with substance abuse, there's been more a push toward dealing with the substance abuse and making the PTSD secondary. And often the substance abuse for them has been a attempt to cope with the traumas that they've been through, and the traumas have been many. I guess for the most part too, I've also been in situations where there's been conversations with patients, and they talk about the violation of trust. And that violation of trust, they talk about how maybe when they need medicines, they don't get them. They're given a lesser medicine than they need. They sit in rooms where they're in pain for long periods of time before they acknowledge. And when a person is dealing with racism in this way, there's a kind of a demeaning of that human being. My pain is second. I'm second. I'm less than. And so even seeking out help sometimes, which they often sometimes can so desperately need when you think about heart disease and other things like that, that women may suffer from, rather than go to the doctor, they'd rather not go. Because it's almost like going to be waited on in a restaurant. And while I'm here, there are other people going before me. Their pains and their things are more important. I've had young women talk to me about having babies, and in the process of having babies, they will have a counterpart or another person having a baby, and they will say that they have talked to their friends and they were given medications that assisted them perhaps through the pain, and whereas for them, they felt they suffered much longer than they needed to. When a person feels less than, they don't feel they'll be treated the same, no matter what their situation is, whether you're talking about this piece where we're talking about the medical care that they need, or even sometimes even in mental health. So when they talk about this, they talk from a place of what was being spoken about earlier. It's not a fantasy. It is documented that those African Americans there in the Tuskegee study, those were real human beings. And, you know, it's one thing when you don't trust because you don't have a reason. But when you have things documented like that and you can point to it, then you can understand how a person may feel less than. I am not worthy. Someone is more important than me. And oftentimes, even when you're thinking about when it comes to medical school or any other, how much is focused on when it comes to diversity, when it comes to sensitivity and dealing with the clients, like was mentioned earlier about the thicker skin. Education is crucial and important, breaking those stereotypes and myths. That is how we're going to have to crash through these issues, because right now it's affecting us, especially like in this time of COVID, where you have individuals that need the help, but because of that trust and that violation, we stand still in the space of having no trust. Whether it's women, whether it's men, whether it's mental health, whether it's even medical care for serious things, life-threatening as COVID. So for me, when I think about my many years of doing this, I've heard this in so many spaces, from younger people, from middle-aged people. I've worked with couples, individuals, families, and groups, and the gamut of the diagnosis in the DSM-5. So for me, that's what I see. It's like a mobile. When you touch one part, all the parts move. A person's mental health, physical health, spiritual health, and all of it. The whole person is affected. And if I go somewhere and I feel like I'm not going to receive the services that I need, there is a thought, why go at all? This is what we have to educate people about and deal with when it comes to dealing with this racism that is in healthcare. And we have to be straightforward with it, addressing it, because there are too many people suffering because of it.
Thank you, Dr. Shea, for sharing that. And as we talk about racism in the medical field, it brings me to speak out. You know, there's so many commonalities here when we hear about racism, and as we are looking at law enforcement constantly, social media, the news. I mean, you can't go anywhere without hearing about the racial practices in law enforcement. And so, you know, I'm so honored and humbled to really have you here, because it's important to have law enforcement's voice in a space like this, so that you can share your best practices and any challenges that you all may have. And so it would be great if we could hear a little bit about what your experiences are in this space of dealing with racism in law enforcement, and how that might be able to help us begin combating racism in the medical field.
Okay, I know y'all first asked me to be up here. I was like, what in the world would I have in common with doctors, and I'm a police chief? But when I look at it, I think you'd be surprised how related our fields are between the police officers, and you look in the medical profession. With us, how we dealt with it is our mistakes are completely public. When we have anything that happens, anything like that, from our body worn cameras, anything, it goes public. And so that public oversight for us has really shaped the way we do business, because we can't hide from it. We see it every day. And what it's done for us has changed the way we even train. For us, for example, for us in Virginia, to be a police officer, you have to every year go through cultural diversity training, which includes explicit and implicit bias. That's required for us. Everybody has to go through it. And our academy is taught to be certified as an officer. You have to have that also in our police academy, that type of training on explicit and implicit bias. And one of the most important things we looked at was not just hiring someone just because they're Black or minority. Are we hiring the right people to work in the city that we live in? If you have a city such as ours that is predominantly minority, do we hire the right type of officer that can work in that type of environment? Because not all officers can. And I guess I look at it sometimes from, I guess it would be similar to you all in hospitals. Are you hiring the right people for the environment that they're working in? Are they prepared to know that this is the environment I'm going to work in? This is the racial makeup. This is the income of the people. And I look at it, each hospital is almost like a mini police department, like ours. And so that it comes down a lot to leadership. Does the police chief tolerate bias and racism? And it wouldn't matter what type of people we hire if we tolerated that type of behavior. So it's like with us, if I see an organization, a police department, where you see systemic racism, that means that the leadership has accepted that type of behavior and it filters down. So what we've had to do is that almost change how we even hire the leadership and what's acceptable. When I first came on, the racial jokes and all of that was acceptable. It's not anymore. We have a lot more self-policing where between our officers, they do report that more and they feel open to where if I do see that type of bias, I do see that type of discrimination, they openly report it. We look at also is that, and we notice too, if I see an officer, it depends on where they're working in an environment to where for us, I can go by our numbers, the majority of the violent criminals that we deal with are normally African-American. So it'll be easy for a person to have their whole judgment skewed to where if the people I arrest are African-American, then every African-American male I deal with it then is probably criminal. So what we do in situations like that, we try to rotate people to try not to have them in that same type of environment the entire time. Give them different, they have those different assignments they can go to, but also to monitor. And if we start to see certain things that happen, we try to intervene on the front end of it. And also you have to have, for us, we look at discipline. There has to be some type of discipline or some type of consequences for your actions. And it has to be swift. If there's no consequences for your actions, then it'll continue. And if people don't know that there's consequences for those actions, it'll continue. Where we've been fortunate in the police business, from our different organizations, from International Association of Chiefs of Police, from the President's Council on 21st Century Policing, we've had to go through a lot of soul searching and we had to look inward into the things that we're doing. At first, we had to admit that we had a problem where it had to be accepted. And instead of us also saying that this is the problem, we had to show these are the steps to correct it. And we have the public oversight where our citizens, for example, my city in Hampton, they let us know up front that we're being treated a certain way. We don't like the way you're being treated. And we make our decisions based on that. And if I was looking how you relate to the medical profession, how we can relate to it, is that do patients have that same type of input where they could feel free that we could go to the hospital doctors, we could have these types of open forums and sessions where automatically to say that this is how we were treated and what type of change would it have? Could it be where they have that atmosphere where everybody can have those open discussions? And we have our internal affairs, and I'm quite sure a medical professional have something similar to that. But when you do that, when you have those type of internal processes, the mistake that we did in the police was for so long, we were like, we know what's best for us. We don't need any outside intervention. And that became a problem because if you start believing that nobody knows your profession but you, then you'll never make any type of change, because what'll happen is that it'll be like only police can judge other police, but we found out that's not necessarily correct. And you have to be open to that outside type of criticism. You have to have that outside oversight and be open to it and not be as, and you have to have a thick skin to say that there's probably some truth to it and be willing to change and lay it outward to this is what we're going to do. And everybody has to know from top to bottom. And what we found that worked good for us also in our training is role play, is that when we did certain type of training, when we actually had different, like for us, we had a reverse roles where the citizens became the officers and the officers become the citizens. And when we switched roles, it was amazing how everybody actually saw that this is real behavior that can happen to us. And I look at when you do your training also, a mistake that we saw that we would make is never mix superiors and subordinates together. If you're going to have any type of training, don't have your supervisors with your subordinates, because you're not going to get open type of communication. If you have people who are in charge and you have real open discussions, and the person who you is having those discussions can affect your employment, they're not going to be open. If you have people that are equal together, have supervisors with supervisors where there's real training, you'll get more open input from it. And just don't have it to where, since it involves racism, it's got to be someone Black who deals with it. Since it involves sexism, it's got to be a woman who always has a problem. Why can't it be everybody? It's everybody's problem. And put it out to everybody, it is everybody's problem that I'm responsible for the person beside me, regardless of their color. And I have to treat everybody the same. And it has to, like stressing, it has to come from the top. And I guess the equivalent be to us, I like to go to an area where we have our people patrol at night to see what it's like. To see what it's like for them to be in that neighborhood, to see, okay, this is what it's like for this person to walk to a bus stop. This is what it's like their everyday life. And I think if you don't have that sensitivity to the person you're dealing with, then you don't look at them as human. And I guess for y'all to be equivalent to where if I go to the emergency room, for me to get care, do I have to say I'm Assistant Chief Gallup? If they know my title, or they treat me the same if I go in there like everybody. So if you want to see how it really is, just go to a place and don't use your title. Go in there and see, would I get treated the same if they just saw me just walk in there? Then for me, I get a better view of how are the policies that I'm putting in place actually working.
Well, thank you for that. You said so many things that are so important, and I know that our time is so tight here today. I'm just really looking forward to the continuation of these discussions. But as I listen to you, I think it's, adding value to this space for me to share that my experience has been somewhat what you just talked about, where if I'm in my primary care physician's office or if I was in an emergency room, the experience was very difficult, because one of the things that I can share is that I was really, really sick and overweight, high blood pressure. I was like almost 260 pounds. I was born into trauma. And so my situation didn't afford for me to have resources and ability for someone to tell me that trauma could impact me in a way where obesity was a factor or high blood pressure, right? I'm just this person that came out of foster care and had a really rough time. And so I lived the majority of my life that way. And my experience with a lot of doctors, white males, were either that of disgust, because they would say you're morbidly obese, not even consideration that my frame might be different because I am a Black woman, but also would just think that I was being lazy or that I didn't want to learn how to be healthy. And the solution was a prescription. And it was not until I changed my doctors and sought out a Black female doctor, Dr. Shauna Johnson, actually in Hampton. And she took the time to treat me, as Dr. Shafe said. She treated me well as a human being. And she shared with me why I was in the position and condition that I was in, and encouraged me to make sure that the healthy eating, and then also seeking out someone like Dr. Shafe, and just gave me the resources that I needed to be healthy. And so my journey began, and no high blood pressure, still working on getting the weight down. But at 50, I think it is what it is for me. Stay where I'm at. But ultimately, I get what you're saying. But Dr. Ritterman, I mean, your presentation today has been so amazing. And I really hope we get a chance to have extended conversation with you so that you would be able to continue and finish all that you were sharing with us here today. And as we get ready to wind down and hopefully get some questions from our participants here, that we're able to give more information. But I would ask that, Dr. Ritterman, if we should start with you, and then Dr. Shafe, and then with Chief Gallup, if you would like to leave us with something important that we can take away with today from you about how we can combat racism, I guess in any space, professionally or personally, it's going to help us all.
Well, I love what you said about trauma. And I think there isn't enough emphasis on adverse childhood experiences and the degree to which trauma, even intergenerational trauma, really causes problems in our health. So I just totally love that you had the courage to share that, and there's a lot written about trauma. So I think that's another whole area we really need to look into further. There's a Canadian doctor, whose name I'm forgetting now, who's been part of a movie on this with trauma. So Gabor Mate, somebody put it out there. So I think that's another whole area for us to look into. I'd like to suggest that our doctors and other healthcare practitioners who are part of this use this experience as a way to be inspired for more self-education, to start book clubs and other things to educate our colleagues and our peers, because there's an awful lot of scholarship out there. I love Medical Apartheid as a book that it's on 404 pages. It's an undertaking to read it, but I think it would be really helpful for doctors to take that on and share it with colleagues. Be inspired, be the one to say you're going to make the change, be the one to say that you're going to bring it to your colleagues. Let's bring this back again for more discussion. And again, I think a panel on trauma and how that's impacts people's health would be another very helpful adjunct to this, and that also is part of the chief's experience. He's dealing with people in his communities who have suffered trauma, and that's part of why they're acting out, and so they're not going to do better unless we help understand the trauma that they've been through and really respect it. And I've been a person who hasn't been subjected to that, so we really need people to be sensitive to those who have really suffered through that.
Thank you again. And Dr. Shafe, if you'd like to give us a 1 minute statement. Did we lose Dr. Shafe? I think we might have.
Well, I'm here. No, I'm here. I'm sorry, I'm here. The one thing that I'd like to share is just the idea of trauma, because a lot of times in trauma has layers. And it, just as what was mentioned before about adverse childhood experiences and such, there are many layers that come in one lifetime when it comes to trauma. And I agree with the doctor there that is definitely something we need to touch back on. With regard to us as professionals working in the community and dealing with people, the difference is in those settings where people are in healthcare, whether it's medical care or mental health, those are not necessarily under the eyes of the public. Those are private, confidential, and are in doctors' offices or in different settings. One of the things I encourage us to do is to listen. Listen to people as they talk about experiences where they perhaps feel that they were treated a way that disregarded their illness, their sickness, and also educate them to ask questions to their doctor, to speak up about what their experience is. So it becomes a bit different in healthcare in the way that there is not another eye looking on. It is me alone in the doctor's office with my doctor. And if I'm experiencing a bias, if I'm being racially treated, that will not be known about by anybody except myself. And if I walk out that door, that I share it with someone else. The other part of all of this is all of these things cause distress. All of these things are very emotionally damaging to a person, to feel that I'm not important. What is happening to me is not important. Or because I'm Black, someone white's going to be serviced first. They're going to get the medicine first. So we have to understand that these things definitely affect our mental health. As I stated, not our mental health, not just our mental health, but our physical health. When you touch one part of the mobile, the whole thing moves. So it's not like you can have an individual that is in a situation where they're being treated racially in the healthcare arena and not all aspects of their life is being impacted, even their children, their family, everybody. And so for me, the thing I pass on is to listen, to educate the individuals that are sitting in those offices, to ask questions, to talk about what they're experiencing, and to do what we're doing now. Have forum, have conversation, bring it out, talk about it, open it up, so that that begins to help those that are in these professional arenas also deal with their biases and begin to confront perhaps some of their own issues that they may not right now be able to see.
Thank you, Dr. Schaefer. I know that we're pushing in time here, and I'm hoping that you guys can give us a few more minutes. This is such an important conversation, and I just want to acknowledge the people in the chat. Thank you so much for the comments, and Darlene Lawrence, thank you for the comment there. And Chief Gallup, as we get ready to transition back here to Farheen, what would you like to leave us with now that you understand that law enforcement and the medical field, not just first responders, you are first for the scene for everything, and it's going to take you all working together for us to really dismantle racism in both spaces.
There are real consequences of racism. For a lot of things that we did in law enforcement, you have people who get actually shot who won't cooperate with us because of the experience they had with us, who don't believe they'll be treated the same. So there are real consequences you have from all that type of behavior, where people who are actually victims of violent crime won't come to us. We have people who see things that happen on a daily basis who won't come to us because they believe that because they're minority, Black, any type of minority, that they won't get treated the same. You see it where people tolerate more because they're like, this should be acceptable in my neighborhood, which it can't happen. The hardest discussion to have is about race, especially with your friend and your colleague. And that's why it's acceptable. It goes, I would say acceptable. That's why it happens, because we're afraid to have that uncomfortable conversation. And all of us have our income, our jobs, and sometimes it's easy for people from the outside to say, why didn't you speak up? But then you talk to people and they're like, I'm afraid of what might be the consequences. And we don't speak up when we should speak up. When we see something that happens that we'll allow it to happen and we become the problem. And the way we always look at it is that the first time you see something wrong, or you do something wrong, or you see somebody treated bad, that's always the hardest thing, because that first time it happens, for you to accept it is a totally against your system. But each time you allow it to happen, it becomes easier and you start to justify it. And it gets to the point to where you start to blame the victim. Well, it's your fault because they treat that way. You shouldn't speak out all the time. You shouldn't do this. And that's what's happened to us in our profession. It happened to us in law enforcement. And to turn it around, it does take time, but I look at it, we have to change ourselves first. You have to take our own look and be honest. Is that, what am I doing? Am I contributing to the problem? And if you don't do that self-assessment of yourself and say to yourself, why did I allow this person to discriminate against this patient? Why did I allow this officer to treat this person that way? If I didn't say anything, then I become the racist. I become the one thing that I said I never wanted to be.
Well, as I close this session, I have to just say thank you to Doctors for America for stepping up and for standing with us all and making this possible. And then, to definitely thank our speakers, each one of you, Chief Gallup, Dr. Shave, Dr. Ritterman, and to mainly thank each one of you for showing up tonight. this work is hard, and we know that you all need support. And in this current environment, I can only tell you that you have a world standing behind you and wishing you all the best and hoping for the best for each and every one of you. I can say, keep doing what you're doing. Know that you have support in the community, and we will fight this fight with you. This is not just about patients. This is also about doctors. This is also about you. And so with that said, thank you for allowing me to moderate this evening, and I will give it over to Farheen.
Thank you again, Kayla. Thank you to all of our panelists for joining us this evening, and for everyone who joined in on the conversation tonight. We would love to hear what you all thought of tonight's session, and also just feedback on how you would like to see DFA engaged, and if you'd like to participate in that engagement. We are going to be having an event on October 18th for the gun violence subcommittee that does work within racism in medicine and other topics as well. You can find a link here in the chat. I'm dropping it here. If you'd like to RSVP to that, that will be October 18th. And otherwise, please find Doctors for America on multiple sites, including Twitter and Facebook. Again, if you have any comments, if you'd like to engage in other ways, we'd love to hear from you. We hope to see everybody on October 18th. Thank you again.